Good morning, everyone, and either welcome or welcome back to our Black History Month conference that's ongoing throughout October. For those that this is your first webinar, the conference title is Global Communities, Local Challenges and Partnership Solutions. And the main purpose of why we're doing this conference is to celebrate, enable discussion and help us move towards better solutions that create sustainable change, as all of us are likely going to be working in some sort of healthcare, public health sector or working closely with communities. And we want to look at enacting sustainable change. These webinars are going to be used as an opportunity to bring some visibility towards some of the data and some of what we can use to use a data-led approach to creating solutions. Now, all of the webinars are going to be focusing on three key themes. So we're either going to be looking at celebrating, connecting with communities, sharing emerging practice and learning, or shining a light on the issues. And that's going to be the focus of this webinar. And I'd also like to highlight that we had a webinar on Wednesday, which was very similar, where we shared emerging practice and learning from some of our engagement partners relating to our Somali, Nigerian and Caribbean community engagement partners. They will be going live on the Healthy Brum YouTube channel. So if you could pop a link to that in the chat, Joe, they will be going live on there over the next couple of weeks. So please keep an eye on there where all of those webinars will be posted. And also, if you're interested in any of the other webinars that will be happening throughout this month, please go to the Black History Month Eventbrite conference page, which will have links to all of the other sign-ups. I think there's a couple more ongoing today as well, so head over there and have a look. Also, before we get started, just quickly going to go over some housekeeping rules. So we're going to please say keep our microphones muted and cameras off unless we're talking about questions, just to help with bandwidth and help everything move smoothly. This will be quite an interactive webinar. We will be using Menti today, so I'll help you join that once we get to that point. And there'll be lots of opportunities to speak and get involved in some discussions on looking at data and improving health. So just a quick overview of what we're going to be looking at today. We're going to have a quick overview of the community health profiles and how we can use these as key sources of information to help improve community health, how you can actually use these profiles, then quickly looking at some of the key data and understanding the complexity and the intersectionality of some of the data and how just a one-size-fits-all approach isn't going to be the most relevant when you're trying to tackle inequalities in certain communities. And having that increased understanding and awareness and that cultural competency hopefully will help us provide better healthcare for our communities in Birmingham. Then going to go through just a couple of case studies where we can look at some reflective learning on what has been done before and maybe how we can improve and what we can do going forward. And then we'll finish up with some recommendations and some considerations for a Birmingham-based approach, and we can discuss those in more detail as we go through. So just starting off, I'm going to talk a little bit about our community health profile work, and specifically we're going to be focusing on our Kenyan and on our upcoming South African and Central African countries' community health profiles. I have a quick poll, which we launch at all the beginning of our webinars talking about this, is to just understand who is aware of these tools and who uses these tools in their work. So this will be a poll that should just pop up on your screen in Teams. So that should just come up now, just so we can understand who's using our work and if we need to improve it or tailor it in any way to make it either more relevant for the healthcare professionals that are using it or for community members that access it and have opinions on whether or not it is reflective of their own experience, so we can have that reflective learning ourselves and understanding that these are a great tool to start with, but there's always room for us to improve, and we would kind of really appreciate any of that feedback. So just check that's working. Yep, I can see that coming through now. So thank you to everyone that's kind of answering that. And I think that's pretty much most of the people in the room have answered already. So it looks like we're going to get some good engagement today. So thank you all for that. So a quick overview, as I'm aware that some of you were in the webinar on Wednesday, so I don't want to repeat myself too much, but for those that aren't aware of these community health profiles, which is about a third of us in the room today, they are a very comprehensive desktop piece of work. So essentially a very comprehensive literature review looking at a specific community of interest. And our main purpose of doing this is understanding that a lot of previous reports focus too broadly on groups and will look just at either the acronym of BAME or will look just at an overarching community, which is not good enough to understand the specific health needs of our communities. And as we'll see today, people that are from South Africa will going to have very different health needs of those from Central African countries, and we have very different demographics and health needs of those from Kenya. And it's important to identify those differences and not just group everyone together because they're from the same continent or because they're the same ethnic group. And I think it's a really good tool to understand those communities in more detail. Each of these profiles looks at the whole physical health, mental health, wider determinants, lifestyle and behaviours of a specific community. So they're really broad, and no matter what kind of aspect of healthcare or public health you work in, you should be able to take something relevant away from these profiles and integrate it into your daily work. We closely align these profiles with the themes in the health and wellbeing strategy, which I'll cover in a minute. And then we also understand that just having a piece of paper on a shelf is not good enough to, again, effectively engage. So a lot of these profiles, like you will have seen on Wednesday, have engagement partners that actually work in the communities and a lot of the times represent those communities themselves to increase that cultural intelligence and disseminate them and engage with them in a culturally relevant way. Now, some of these profiles haven't been published yet that we're going to be talking about today. So this is going to be a great opportunity for us to have some of that pre-learning on how we can engage best with those communities, and having that group discussion will be really useful. As I said, we're going to be focusing on 3 of the community health profiles today. Now, 2 of these profiles haven't been published at the minute, so please keep an eye on our communities team webpage on the Birmingham City Council website around about the end of December to the beginning of January, as that is when they're likely to go live, and we can share them all with you there. There is also a communities team mailing list, so the moment they go live, we can share them with you. So if you'd like to be added to our mailing list, please let me know. I have just again shared another quick poll, and that will keep you up to date on the most recent updates and when they're going to be coming out. So I'll keep that running in the background just for a minute. So first and foremost, just how to quickly access these profiles. The Kenyan profile is live on the website at the minute. You should be able to click the links directly in the webinar. So if someone could give me a thumbs up if they're able to click on one of the links, that would be great. And each of the pages has a whole variety of resources that you can use. Brilliant. Thank you for the thumbs up. Great, glad that everyone can access these. There will be a full community health profile report on each of the web pages, varying lengths. I think the Kenyan profile is 61 pages, and some of them range up to about 150, 200 pages. So they're quite comprehensive. So alongside that, we do have some shorter infographics, which are 4-page summaries, a little bit more visual and easy to digest, especially for those that don't like huge reports and it is a bit overwhelming. Also great to share with community as well, as they're a little bit more short and snappy. For relevant ones as well, we do have translated documents as well. And there is going to be some census update infographics when relevant as well. So all of those links should be accessible there. And again, just a bit of a promotion that our South African and our Central African countries profiles are going to be up again end of December, beginning of January. So expect a full written report. There will be some additional resources that we're currently creating to support that. And there will be some launch events going on between February and April next year as well, where we can really delve into the specific health inequalities that were uncovered and what the next steps are for tackling those health inequalities. So just a brief overview of what these profiles cover. As I was saying, they fit a lot closely with the health and wellbeing strategy, creating a bolder, healthier city, which again, you should be able to click on and find. And this strategy splits things up into these key sections that you can see on the right hand side. So getting the best start in life, mental wellness and balance, etc. And they either focus on specific areas of health, such as physical activity or diet, or they focus on different points of the life course, such as aging and dying well and getting the best start in life. Now, each of these topics within the profiles are going to dive into many different subtopics. So, for example, in the protect and detect profile, protect and detect section of the profile, we'll look at screening, we'll look at vaccinations, we'll look at sexual health, we'll look at COVID-19. It will split up into each section between, I'd say, 3 and 15 subsections. So a lot of data within them. And we're not just looking at key statistics, so prevalence and incidence. When the data is available, we're looking at beliefs and attitudes, knowledge of a health topic, understanding of the current healthcare system, what services are available, and if there's any barriers to actually taking these services among a specific community, and what we can kind of do to help facilitate those services and make them more relevant for our communities and more accessible for everyone in Birmingham. Now, just a quick overview of some of the ways that you can actually use these profiles in your work to help increase health outcomes. So we can look at purely from a knowledge and an awareness standpoint. We can increase cultural competence within the workplace by actually understanding our communities and being able to offer that appropriate, culturally relevant healthcare and delivering healthcare, whether it's face to face in a more clinical setting or whether or not that's in a public health more background way, being able to develop systems and services that are culturally relevant and appropriate. They can be a great key evidence source for using the data for health promotion projects and commissioning of primary data collection where there are some gaps in the data. And that is the one thing that these profiles identify, is there are going to be gaps in data, especially on a Birmingham level. And it's a really good opportunity to use that as an opportunity to advocate for these communities and say we need more data to understand their healthcare needs and be able to provide that care. And it's also a good tool to be able to collaborate with communities and advocate in that, creating the change within these key areas. The first question that we're going to be looking at, because I'm aware that it's not sharing on the screen properly, is if you have used these profiles before, how can we improve the data that's within the profiles? And if you've not used the profiles before, so you're not sure, how can we increase the dissemination of these community health profiles? What channels or what routes or what paths maybe haven't we explored that means that you yourself haven't heard of these profiles, to help us kind of get the word out about this tool and make sure that we're going down the routes that people are actually going to engage with? Thank you. Yes, some really insightful responses here. So having things printed in GP surgeries, I think could be a really good idea, especially if we find some kind of shorthand versions, because again, I don't think GPs would appreciate us sending 200-page documents, but definitely having some key highlights. Some of the, I like this one about consulting with the community and asking where and how they'd like to be informed. I think that's obviously the best thing to do, is having that bottom-up approach of us asking rather than telling what's going to happen. I think it would be great if we could find some ideas on how we initially reach some of these communities if we have not explored the right routes. But I think definitely having that face-to-face approach. Some of these platforms we do use, so things like social media and email. So I think potentially we need to explore getting those messages out to the right people on those channels. So thank you, all really helpful. Thanks. Also, let's move on to a little bit about what the data is actually telling us at the minute, and now what we can use it for and what we can do with it. So one of the main sources of information that we use in the community health profiles is the census, because it's going to be the most comprehensive in terms of numbers, but it can only tell us so much. So we do also rely on a lot of scientific journals and a lot of other national data sources and local data sources, such as data collected by the NHS and GPs where possible. But the census is a really good start point. And what we can actually get for these specific communities is there is data available on national identity or country of birth, which is really useful at getting a broad idea. However, there are going to be some limitations to census data in this sense. So if we're looking purely at country of birth, that's not going to look at second generation migrants. It's only going to give us the estimated for first generation migrants, which is likely only going to be a fraction of some of these communities, meaning that a lot of the times the data in terms of numbers and population sizes are going to be an underestimate. So the communities are going to be larger than what it looks like initially from the data. And again, when we're looking at country of birth data, it is generally limited on local data, so Birmingham based, and it's typically only available for a West Midlands or an England and Wales level. So again, really good starting point for us to identify those gaps and really identify the need for Birmingham based primary research into a lot of these areas. But there are lots of merits still to the census data, such as looking at geography, population estimates and distribution around Birmingham. So if you're looking at any place-based approaches to health interventions, it gives a good idea of where in the city communities are going to live. It gives us a rough idea of some broad demographics such as age, passports held, country of birth, migration. It gives us some ideas of some other characteristics such as English proficiency and religion, which again, when you're creating resources that are relevant to a particular community, are really good things to consider on whether or not you need things to be in simple English or translated, and again, making them culturally relevant in terms of religious identity. And it also looks at some of those wider determinant data, so things like highest level of qualification, occupation, housing and overcrowding, etc. If I can swap here. So some of the key findings from our census that we can see is on screen now. So just kind of a brief overview and I want to highlight a couple of the data points again that talk about that underrepresentation. So when we look at the Kenyan community, for example, when we look at those that identify as Kenyan, when you look at the ethnicity strand, there's only 270 people that flag on that, which may mean that it looks like quite a small population on the surface. However, if you look at that country of birth data, that increases to 8,675, so a much larger population compared to the 276 for ethnic group. And again, like we discussed before, even that's going to be an underrepresentation, isn't going to account for those that weren't born in Kenya, those that were born in the UK or born elsewhere and migrated to the UK. For all of the communities, we can see rough estimates. Again, the community health profiles will delve deeper into the top MSOAs and not just these overline headline datas. But for example, if you wanted to target Central Africans in Birmingham, you would be looking at going to North Central and Dartmouth Circus in terms of the MSOA being the highest percentage population there. And again, not all of this data is going to be reflective. Like I said, we can also get data based on community of identity, so those that have a national identity that aligns with the countries on screen. However, again, this is only going to account for a very small portion of the population, but it does give us different demographics in terms of some of the religious outcomes and some of the ethnicity identifiers. So it's important to consider there are multiple factors, and all of these are going to be very intersectional in terms of our data. There's going to be lots of overlapping factors. So it's important to not just take any one piece of data and assume that that's kind of the be all end all, and that's exactly what a community is going to identify with or exactly the truth. And there's going to be lots of different factors that we need to consider when looking at those aspects. So one of the really useful tools that we have built to help summarize some of this census information, this will be shared after the webinar as well in the slide deck, but we have the census infographics which briefly summarize that key data and talks about the national identity, qualification, etc. So moving on to the understanding of our community identities, and again, touching a little bit about on that intersectionality, that it's not just a simple blanket of you're from this country, therefore we need to engage in this particular way. And actually looking at ethnicity and identity and health is really important because our ethnicity is going to affect our health, and it's going to be a combination of so many different things. So a combination of some social influences, political influences, your race identity, your cultural background, your religion, etc. And you can see there's a couple of ways on screen that I've got that ethnicity affects our health through cultural behaviours, through habits, through your religion, through disease prevalence in particular races. So it's important to understand the ethnic mix of a population to actually improve our healthcare delivery. And as I said, not have just that one size fits all approach to someone just because they're from a particular country or because they're of a particular ethnicity. And talking about ethnicity, I've highlighted some of the key ethnic groups that come out of these community health profile data. And again, there is the census building tool, which if you're not familiar with, I'll quickly show you as a great source of key information that you want to pick out. Most of it will be plugged into the community health profile, but if you want to do some more digging, the census building tool is a great source, and I'll show you that in just a second. But just really important to highlight that actually there is such a wide variety of ethnicity spread when we're looking at these three populations within the UK. So for example, if we want to target Central Africans, we are looking at majority Black African or mixed Black African ethnicity. Whereas if we're looking at Kenyan, actually, there's going to be almost 2/3 that identify as Asian and not Black African at all. So it's really important to just not make assumptions just because someone is from an African country that they're going to identify in a certain way ethnically. So just quickly showing this census building tool. So what this tool is really useful for is creating custom data sets. This comprises all of the data that was in the census, but in a really user-friendly way of being able to get data. So the main thing that you're going to be looking at is usual residents, unless you're looking at specific household data. And it has a whole host of variables that you can add, and you can get that multivariate data. So you can look at how country of birth, and you just add it in, will affect things like your general health. And you can add in a couple of variables. Some of them you can add in 2 or 3, and some of them you can only add in 1, but it's really useful to have a play around with, and you can change the different coverage. So if you want to look at a local level or a national level, again, not all of it is available either based on what was or wasn't collected, or what is and what can be shared for avoiding identifiable data. So census isn't going to publish anything where you could pick out a particular person, especially as some of the data that they've asked about can be quite sensitive and quite personal with some of those health topics. So again, just to kind of summarize those community identity datas for the 3 communities, we can see again a really large breadth of religions, from being Hindu majority, Christian majority, from having some that are like 13% Muslim to having 5% Muslim. In South Africa, 30% have no religion. So again, a large variety of what we can expect to experience based on the different country or countries that we're going to be looking at. And the one that I'd like to highlight most on this page is English proficiency. So actually, depending on who we're speaking to, you may find that if you're speaking to someone from South Africa, there's almost going to be a 100% chance that they can speak English as their main language, or at least can speak English well. Whereas if we're speaking to someone from a Central African country, there's going to be around about a 10% chance that the English proficiency is not there. So really being considerate in terms of what languages are available for those resources in, how the language availability of services and resources might impact the access to those services, and just thinking about some of the inequalities that might come from some of those statistics. What can you think are maybe some of the limitations of some of this data, some of which we've covered, and what are some things that we might need to consider using this community data to improve health outcomes? So a bit of a tricky question, but just really kind of engaging what do we need to consider when we're building these interventions and when we're looking at this data to really make sure that we have a considerate response? Yeah, absolutely. Things like especially using the census, if they're not very frequently collected, then things can change quickly. So there needs to be that frequent local level data that helps support our findings, because yes, that's going to be a main limitation when we're looking at health programs. If we're using data from the 2011 census, which some of the multivariate things haven't been released from the 2021 census, then things could have definitely changed massively. Yep, drawing conclusions from small numbers is definitely a limitation. So we make those assumptions based on some of those survey data, when actually, if you take that to the wider community, they find that that's not their true lived experience. So again, really highlights the importance of us having that collaborative approach. Absolutely, yeah, making sure there's a really good point, making sure that the actual data is correct, and again, engaging with those communities, making sure the census is right. Again, linking back to when we talked about English proficiency, making sure people have understood the questions, making sure people have been given equal opportunity to properly fill out the census and have had the correct support for that, so that the data that we're seeing is correct and reflective. And yeah, absolutely, that kind of links exactly onto this next point. I didn't even see that. So perfect. Yeah, that comprehension of what is being asked and its relevance to those, and people understanding why we use this community data. Because a lot of the time people may say, well, why do you need to understand my ethnicity? Why do you need to know my religion when I'm coming in for something medical that's completely unrelated? And it's making it really clear to those the relevance of, well, if we have this data, we can provide better healthcare to you, and making it really clear. And yeah, absolutely, the questions that are asked are limiting. So a lot of the times, thankfully, they're for the 2021 census, things like ethnic group, it was a write-in response. So there was, I think, over 200 different categories, which is great in enabling people to respond in more accurate ways, rather than a lot of the data sets are a little bit more limiting in terms of categorizing people into those smaller groups that may not truly express someone's identity properly. Some really good answers there. Thank you for everyone for answering that. So yeah, absolutely. Some of those things have already been highlighted, but just some of the ones that I put on board is the limitations that we've talked about. It only is going to show a certain subsection of the population, whether or not that's based on it being you only see country of birth, or like some of those responses are Menti identified. If the questions weren't fully comprehended, it's not going to be answered properly. So it's not going to represent the whole community. And again, it doesn't necessarily consider some of those more complexities and intersectionalities that are going to exist within every community and every identity. And it can be very much put in a box sometimes. And some things that we need to consider is there may be multiple approaches or multiple sources of data that we need to strengthen our understanding. And again, having that kind of community-based intervention as well, of them telling us how to collect data and us what their thoughts and opinions are. Having that whole approach might be needed to improve the health of a particular population. And one thing we need to consider when using data, which we'll lead on to next, is whether or not we look at targeting a whole broad group, so looking at extending back out to those just overarching Black African, or whether we go narrow and focus on specifically Kenyan or specifically South African and look at how does that change our outcomes in health improvement projects, and what are some of the benefits and the drawbacks of using both approaches. So one of the things I'd like to quickly touch upon, and one of the things to consider when you're planning community interventions, is this thing called the prevention paradox, that actually those that are really high risk of a certain behaviour or a certain health outcome, there may be way fewer people there. So even though they're at the highest risk, if we have a health intervention targeted towards them, it may only impact 10, 15, 20 people, but they're the ones that are at the highest risk. So the one I've put on screen as an example is data on HIV prevalence. Whereas if we look at the wider, and instead of looking specifically at Central African and targeting those specifically from Zambia or specifically from Equatorial Guinea, do we look at doing an intervention on Black Africans, as it's been identified that there's a higher risk of HIV and it's something that we need to tackle. So there's more people there. However, those that are in that higher risk category may be missed and may not be included in that. So you reach more people, and this intervention may reach 200, 500, thousands, depending on the scale of it, but you may miss out some of those that are at higher risk. So there's definitely going to be benefits and drawbacks to looking at both approaches. And in an ideal case, you'd look at both. But we all know that with our limitations, that a lot of the time we can only kind of have one intervention, and it's making it as effective as possible and having the balance between those two considerations. So looking at two case studies that have looked at health improvements. So neither of the case studies, and there's very limited case studies on specific communities, so there isn't really much that we could find easily accessible online. Doesn't necessarily mean it hasn't happened, but found online about specific interventions with people from Central African countries. And most of these look overall at just that overall Black African group. But it's worthwhile just kind of highlighting some of the interventions, what they've done and how they are useful, and what we can take from them and learn from them. So one of the first interventions that I'm going to look at is this Shifting the Dial programme, which overall was a 3-year programme looking at multiple different projects in Birmingham and involving multiple different organisations to help support and improve the mental health of young Black men. And some of the inequality data that we can pull from that is looking at detentions under the Mental Health Act. So identifying that there is a clear need for increasing support. But again, that data was very headline. It only went as far as Black African, Black Caribbean and Black Other. There was no specific understanding of how maybe someone from a Central African country experiences mental health, and whether or not it's going to be worse or better than the average Black African headline ethnic group. So what this programme looked at is developing a series of different projects in collaboration with First Class Legacy. There was a theatre company, and provided opportunities for peer mentors. They looked at youth leads. It was a really community-based approach, and they wanted to look at ways of co-producing methods to promote resilience and finding those opportunities for young Black men. So as well, they put on workshops on increasing access to employment. Again, as we all know, that's going to be a factor for poor mental health, and looking at those wider factors that affect mental health, and understand that it's not going to be, again, just this one approach, that if we look at reducing stigma, all of the mental health outcomes will be improved, and actually looking at things like employment and like community support and understanding how they can all affect our mental health. Again, things like they really tackled experiences of discrimination and racism, and really highlighting that is going to be something that's going to affect mental health, and how we can work together to overcome some of these barriers and help provide support to have the outcomes. So on the right, I've just quickly highlighted some of the benefits of this program, what happened. So there was around about 1,200 individuals engaged throughout the project. And again, when we look at compared to the smaller groups, that is almost half the size of some of those small population groups when we're looking at from specific countries. So it targets a large portion of the population. They've created some key recommendations. There was over 500 young men attending theatre sessions, so really engaging with this project. I want to quickly I think we've got time to play a video.
Shifting the Dial is an innovative 3-year partnership project involving Birmingham Rectory Theatre, Centre for Mental Health, First Class Foundation, and Birmingham and Solihull Mental Health NHS Foundation Trust, funded by the National Lottery Community Fund.
So the Fix It event came together through the partners. So we have Centre for Mental Health, Lightpost Theatre Company as part of the Birmingham Rep, and also First Class Foundation. And we decided that we needed to create an event that actually looks
are at their doorstep.
I think in order to improve the mental health of young black men, we need to have more programs like the ones we've discussed today, programs like Lightpost and like First Class Foundations, that actually encourage young black men to speak. Because a lot of the times we grow up in a society where we don't see black men showing those vulnerabilities, particularly in the media, particularly on, if we want to translate that to social media, we don't see young black men on there speaking about their experiences and how it's actually impacted them in a way that's caused them to kind of internalize those emotions and the dangers of doing that. So I think if we highlight stories like we have today of people that have actually experienced something, but instead of kind of going the other way of not wanting to communicate, they're actually here and they're actually telling their stories. So I think the way we can improve our mental health is by being willing to share and be in those vulnerable spaces to actually know that you are going to be supported and going to be guided through how you might be feeling at the moment. So I think we just need to continue the work that we're doing as a project and find new ways of articulating the nuances of the black experience.
We really need to.
So just kind of highlighting a snippet of that video, I would recommend, once the slides have been circulated, going and learning more about the projects and watching the whole video. Really interesting to see what they've done. But for today, just showing a quick snippet. Again, one of the other case studies that have been highlighted is this HEAL-D. So the HEAL-D stands for the Healthy Eating and Active Lifestyles for Diabetes. And again, looking at how in the UK, type 2 diabetes is around about between 2 and 4 times more common in people from Black African and Black Caribbean communities compared to the white ethnic group. And again, the community health profiles look at some of the specific data on those communities and how diabetes is affected. And again, in the Central African profile, for example, it's highlighted that diabetes in countries such as Zambia is much higher than around the UK. It's about 12% compared to about 6%. Again, this is nationally, not in Birmingham. So again, looking at specific communities, there might be really some countries and some people that we might look at as being at particularly increased risk. But the case studies are really only about that kind of broad ethnic group. And again, not saying that there's kind of one right way or one wrong way, it's just considering those differences between them. Also, in terms of inequalities, on average, people from Black African and Black Caribbean communities will develop symptoms of diabetes around 10 years earlier than the white ethnic group. So what this project looked at doing was creating a 7-week curriculum that focused on making culturally sensitive diet and lifestyle information, having goal setting, regular communication through physical activity classes. And it was piloted and initially trialled with the local community first. So it had that co-produced aspect and what we talked about earlier, that kind of bottom-up approach of really getting communities to tell us how we want to be engaged with, rather than just saying this is what's going to work and we're putting this service on, without any of that communication initially. And so far they engaged with around about 170 people on this project and had some really great outcomes that, again, I've listed on the right, including things like 98%, so almost 100%, agreeing that they now have better management of their diabetes, and stress related to these symptoms has kind of almost halved through this course, and it has a pretty high completion rate that shows that it has been made in a way that people are going to want to access and people are going to want to engage with. What are some of the benefits of these cases? Like I said, looking at that broad approach or that narrow approach doesn't necessarily mean that there's one better than the other. They're both going to have benefits and they're both going to have limitations. But just considering for any health interventions that anyone in this call might want to look at developing in the future, what are maybe some useful things and some benefits that we can take from the case studies that we've just looked at, and how they've used data and how they've used community maybe to influence change? So what are some benefits and what are some positives that you kind of have taken from those last two examples? Yep, absolutely. So going to have better health outcomes, just as opposed to, for example, with the diabetes, having generic diabetes campaigns, or mental health having kind of generic campaigns and general services. So yep, definitely. Absolutely. Community involvement is going to be really important, regardless of what level of community we're going to be looking at. Having the people that we're trying to improve the health of have a say in their healthcare and have a say in how services are tailored is going to absolutely increase that commitment to the services, because you've got things that people want to engage with in a way that's appropriate to engage with, and you're reducing some of those barriers to accessing the services that are available. Absolutely. I think some of these case studies are very inspiring, the way that they kind of tailor to make it relevant for the community, by the community. And I think all of this kind of really focuses on one of the main things to consider when we're looking at delivering healthcare, which is just the importance of community and the importance of not just doing to a community as a healthcare, and really involving people from the beginning, whether or not, say, that's a really small localized approach or whether or not that's a much wider community overarching approach. And yet some of the benefits we can look at, tackling health literacy. So as I say, in that like diabetes workshop and the diabetes course, providing culturally relevant and at the right level information. I think health literacy is definitely something to consider in any health intervention. Brilliant. Thank you, everyone. So what are maybe some things we can learn? What are maybe some things that we can either use from these case studies when we are taking them forward, or maybe even what are some of the limitations and what could we maybe improve on? So even though they're brilliant, what are some things that maybe there's always room for improvement? What can we look at doing in the future? How can we make these more relevant for our communities, specifically in Birmingham, especially as the HEAL-D was a London-based approach? Yeah, actually start using some of the information, absolutely, rather than just focusing on data, is actually going forward and making sure that the whole systems approach absolutely is making sure everybody is on the same level. Absolutely kind of make sure that things are suitable. I'll give it a couple of seconds and I'll kind of put in my own thoughts, but I think both of these comments are absolutely hit the nail on the head, and it's really important to understand that data can only take us so far. It can only take us up to a certain point of view. Exactly, make sure things are sustainable, make sure they actually have an impact on the individuals. And I think that kind of shows us the story that we've had today, that data can be a really good starting point for helping us understand maybe how we can reach things. But yeah, having those targeted interventions to actually with the community, make sure they're suitable. If we do want to focus on a specific community, we can use the data and approach them to make sure that interventions are suitable, but also looking at needs assessments to make sure, is this going to be suitable if we scale it up, if we scale it out to other communities, is kind of absolutely looking at not just the data from a health point of view, but from the data from a community needs point of view. Yeah, absolutely. Wider inequalities are always going to be the best way that we can tackle health. So if we make sure that access to employment is equal, and access to good employment, access to good housing and good education, make sure all of those are addressed, is absolutely what's going to underpin all of these case studies. And you're absolutely right, although they're great, we do need to kind of focus together on that all services approach and making sure everyone's on board to really empower communities right from early life, and making sure that everything is set up for success. So a lot of these preventative programs are in place before health inequalities start emerging. Absolutely. So absolutely. So some of the benefits that kind of I can identify is, again, we reach those larger audiences, we might have that more impactful, we might have those more collaborative working effects, but we do have kind of that uncertainty whether it's actually reaching those. Like some people said, we've got those wider health inequalities to consider. We've got that whole systems approach to consider. I've also noted that we do have limited data on specific communities, specific Black communities that we want to focus on. If there's a really particular need, it's not being identified among some of those intersectional communities, etc. So just to finish up this webinar, quickly just going to cover some considerations for how we can kind of take this forward. And I think some of what the points that we've already talked about today are brilliant in terms of what we can do. Some of these are just going to be considerations. Some of these are general messages taken from engagement partner work that we've had going on over the last 12 months with other communities. So it's not really a hard and fast guide of this is what must be done, but just some things that we can consider to make sure that our approaches are improved going forward, and having like that initial having that local data, making sure we understand our populations really well, making sure we have different messages around health issues. Again, like the comments said, talking about health literacy, making sure they're at relevant levels, they're shared in the right venues, they're co-produced with communities, so they're relevant. And that doesn't just apply to messaging, that applies to interventions as well, and kind of wider services, making sure that communities are on board with the creation of services, and making sure that us as professionals have those active listening skills. We have that ability to provide good services. We understand, especially as a lot of the data from today was talking about migration, that we understand about migration status and how we can provide support to those that have recently come to the country, but also those that are not identified in that data. So those that are second generation or third generation or fourth generation migrants from some of these countries, and how we can kind of understand their health, even if the data doesn't necessarily capture it on a census level or on a national data collection. Again, thinking like having relevant community hubs in Birmingham. Not all of the time we're going to have relevant spaces for communities to come together to share what they need. So, for example, if anyone was in the webinar on Wednesday, our Nigerian engagement partner talked about how there is no relevant Nigerian community hub in Birmingham that can be used as that space to share ideas and to discuss with healthcare professionals what the community actually needs, and having that shared community space that is connected to the local authority and is connected to the NHS or is connected to that wider systems, to make sure that we can really include the community when it's needed to. So just to kind of finish off, looking at what else can we do. So this has kind of been a very useful or very engaging session so far, and a lot of you've clearly got lots of experience and lots of really useful things to say. So if there's anything that you'd want to share in terms of what else can we do to make sure that we're, one, using data-led approaches, which is the focus of this webinar, but also having that kind of compassionate-led approach and making sure that we're involving communities, that we're being considerate of communities. What else can we do to really make sure that when we're looking at specific interventions in specific communities or specific services or that whole systems approach, what else can we do? And then I appreciate we've run over slightly, but if anyone has any questions, I will be around to kind of hang on to answer any questions that anyone has. Yeah, absolutely. So looking at some of those, the multivariate kind of outcomes. So some of this will be addressed in the profile, so please keep an eye out when they come out, looking at things like ethnic group and economic inequalities, and looking at income, looking at occupation. Hopefully that's what you meant. But yeah, absolutely looking at not just one aspect of health, and not just looking at someone's ethnic group or just looking at someone's religion or just looking at someone's economic status, but looking at kind of a cross section of how those are all going to interact with each other, and how that might affect your access to some of those services and what barriers that might make. Absolutely, yeah, really, really good point here about unconscious bias, and really unlearning any of those unconscious biases, and as healthcare professionals acknowledging them and making active steps towards them to be good allies, and making sure that we can provide those services. Looking at, again, yeah, engaging people. I really like that kind of point about unconscious bias, so really important to kind of consider. But thank you so much for everyone for being so engaging. I'm aware it's not the largest webinar, but we've had some really insightful conversations. Yeah, happy to thank you for coming along today.